My name is Uma Mahadevan, and on behalf of myself and my co-chair, Millie Long, we'd like to welcome you to this session discussing the global consensus for pregnancy in women with inflammatory bowel disease. The impetus for the consensus is that there are multiple guidelines and consensus statements from different organizations and countries with some variation, which created confusion and non-standardized care. The aim is a universal guideline with consistent interpretation of data and sensitivity to regional differences. This project was funded by the Helmsley Charitable Trust. So I am the chair, Millie Long is the co-chair and the grade lead. Ed Barnes is part of the grade team. And these are our coordinators and analysts. And we had every continent represented. Sue Eng led the Asia team, Gillian Watermeyer, the Africa team. Emma Flanagan led Australia. Mette Julesgaard led Europe. Cynthia Sal led North America. And Jesus Yamamoto Furosho led Latin America. We also had multidisciplinary consultants, including Phil Anderson, the founder of LactMed, a placental physiologist, teratologist, colorectal surgery, and maternal fetal medicine. And importantly, we had patient ambassadors from every continent who reviewed the questions and participated in the discussion. This was a year-long process that started in April of 2023 and culminated in 2 days of meeting, Thursday and Friday before DDW. And this is us looking fresh on Thursday, at where we met to review the grade and consensus questions. The working groups were divided into 10: maternal factors impacting pregnancy, fertility, preconception counseling, management of disease activity, management of pregnancy, IBD medications during pregnancy, lactation, and pregnancy adverse events, fetal and neonatal adverse events, and vaccines. With that, I'm going to hand it over to co-chair Millie Long to review the grade and consensus process.
Thank you. I will just briefly review the methodology, and then we'll get into our content with our experts. So this Piano International Guideline had a primary objective of really producing a high-quality, evidence-based guideline to answer questions and globally improve the care of patients with inflammatory bowel disease. The process is evidence-based, transparent, and very systematic. Generation of recommendation involves both content and methodology experts. I think everyone in the room likely recognizes that grade is a rigorous methodology for assessing the literature. And this system, entitled Grading of Recommendations, Assessment, Development, Evaluation, really applies a consistent rating to the level of the evidence. Also rates the strength of the recommendation, which can be strong or conditional for, or strong or conditional against. And really, it's evidence-based, but there is an emphasis on patient-reported outcomes, those outcomes that truly matter most to our patients. In terms of identifying questions of importance, each of the 10 subgroups identified the most clinically relevant questions, and actually our patient ambassadors weighed in as to what these questions were. They developed something called PICO statements that involve a population, an intervention, a comparison, and an outcome. Very systematic literature searches were performed for each statement, and then these articles were reviewed by the grade methodologist. Those statements that were amenable to grade underwent the formal analysis. Those questions not amenable to grade, as you can probably imagine in the pregnancy literature, some of this is case series. We don't necessarily have a high level of data, but we wanted to provide a rigorous approach to allowing the experts to give their recommendations in these gray areas. And so for that, we did an expert consensus panel, and we used the UCLA RAND methodology to ensure that there was consistent appropriateness to the statements that we assessed. The RAND appropriateness method is a widely used, it's very iterative and evidence-based, and it combines the best available evidence with the expert opinion. Basically, the experts can interpret the available literature and then provide, after discussion, a consensus vote. RAND panels really require specific definitions and assumptions, and these definitions were made clear to all participants prior to any voting taking place. And importantly, literature, some searches and summaries were available for review prior to any voting. Individuals in this process did an electronic initial vote, followed by intense discussion over the 2-day period that Dr. Mahadevan mentioned, and then a final vote with statements that reached a level of appropriateness being shown to you here today. So in terms of the voting, panelists rated the proposed elements on a 1 to 9 scale, basically ranging from really not appropriate or feasible to very appropriate or feasible for our patients. And in the methodology, we actually quantified something called a disagreement index to ensure that there was a consistent opinion amongst the experts included. Any disagreement index greater than 1 indicated extreme variation, and those statements were not considered appropriate. So with that, we're going to show you the data. So I'd like to introduce Sue, who's going to be speaking to us on maternal factors impacting pregnancy.
Thanks very much, Millie. I think first I really want to congratulate Uma Millie for championing this incredible initiative, which I personally believe is going to not only inform but transform clinical practice. So what you're going to hear is 12 months of hard work. So I think for the first maternal factor part, our statement reads, we suggest that children with first-degree relatives with IBD as compared to those without have an increased risk of developing IBD. So this is conditional and based on low level of evidence. In fact, the best evidence comes from Scandinavia, a population-based study from Denmark, over 9,000 children born with women with IBD and 1.3 million without, and you could see a hazard ratio of 5.68 of the risk of IBD in this offspring. You can also see the risk is actually higher if the mother has Crohn's disease. So earlier studies actually from the Swedish cohort, the multi-generational cohort, has looked at close to 500,000 patients with 32 autoimmune conditions. And you could see here the familial IBD risk in Crohn's is 6.5%, and it was higher again if the affected parents have Crohn's disease than ulcerative colitis. For the consensus statement, the one that we voted on is that children born to parents with a Crohn's disease may have a higher risk of IBD than children born to a parent with ulcerative colitis. And you can see to answer this, we need to ask what's the risk if your parent have Crohn's versus UC. Again, the Danish cohort has shown out of the 5.2 million people, they look at prevalence proportion ratio. This is the estimate number of offspring who have UC or Crohn's divided by what's anticipated in the general population. And this is 9.2% for Crohn's disease. So essentially, if you have a parent of IBD, you have a 2 up to 13-fold of having the disease, and it's higher if your parents have Crohn's disease. Interestingly, offspring had a higher chance of developing the disease the same type as a parent as well. And of course, 2 other Swedish studies and 1 also from Korea have shown the association is higher with increasing number of first-degree relatives, lower age of onset, and if the mother have Crohn's disease. So there are many other areas whereby there may not be consensus or data are sparse. And I just want to run through a few important topics. The first relates to the placenta. I think placenta is one of the most immunological organs we know. And certainly whether the adverse effect we see in IBD will relate to chorioamnitis or abnormality in the placenta. Well, the answer is there's very little data. There's only one small study recruited from the Piano Registry, whereby when they look at preterm infants and also small for gestational age, the placentas from these patients did not show any inflammatory activation. So I think the jury is still out, and we probably need more data to look into this. The second point is we know smoking is a risk factor for Crohn's disease, but what about maternal smoking? Does that increase the risk of IBD in offspring? Well, the data from Manasi Agrawa look at 9 studies, and there was a pool odds ratio of 1.5, but this was not significant after looking at subtypes. In the Israeli study, there was an increased risk of IBD with maternal smoking. Now, I think this is quite important related to intrauterine use of antibiotics and risk of IBD. Essentially, studies in animal models have shown that mothers who are pregnant gavage with antibiotics will transmit certain microbiome that will put the offspring of this mice at increased risk of colonic inflammation. But when we look at clinical evidence, there are several. So the top one is a meta-analysis, and that showed that, yes, there's a risk of basically IBD with maternal use of antibiotics. And if you look further at the Swedish study, they look at the risk of very early onset IBD, defined as those diagnosed younger than 6 years of age. And this is a hazard ratio of 1.93. And a more recent Danish study published last year that further and so that if you have 3 or more courses of antibiotics intrauterine, then this is higher than if you have less courses. So I think the story with antibiotics is that we may not have had a consensus statement, but I think it's important that not to overzealous with antibiotic use during pregnancy. Bearing in mind, these are all from general population data, but where indicated if someone has group B strep, then I think that is an absolute indication for antibiotic use. Now, diet in IBD risk is very hot, especially with westernized and ultra-processed food. There are preclinical studies showing an increased risk in IBD. So the Mommy IBD study by a group, which you could hear the talk presented tomorrow, we found IBD mothers have a higher food additive intake than non-IBD mothers. And this food additive intake, essentially emulsifiers, were associated with depletion in Bacteroides and certain increasing strep. And the fecal calprotectin in these infants born to mothers with IBD were actually higher, who had a higher food additive intake. We need interventional study. So the Melody study led by Mount Sinai Inga Peter is ongoing, asking if you go to give an anti-inflammatory diet to mothers with IBD who are pregnant, could you actually change your microbiome and perhaps over time reduce the risk of IBD? What changes the diet is the microbiome. So does maternal microbiome impact pregnancy or risk of IBD in offspring? The famous meconium study from Mount Sinai has found abnormal gut microbiome composition in mothers who are pregnant with IBD and changes in the diversity. Now, in our cohort, which again will be presented tomorrow across Hong Kong and China, we found that there's reduced commensal bacterial strain sharing in IBD mothers and their infants, and cesarean section and maternal antibiotic exposure led to decrease in some of this vertical transmission. We don't really have any interventional study about whether microbiota modulation may be beneficial, but there are some early work in animals looking at protection from experimental colitis in pregnant mothers with the disease. So for the second part, we discussed preconception and pregnancy management. The great statement is that we recommend that women with IBD undergo preconception counseling for improvement of medication adherence, reduce risk of disease relapse, and also reduce risk of low birth weight infants. And the great recommendation is strong based on low-level evidence. The second great statement is that we recommend that pregnant women with Crohn's disease with active perianal disease undergo cesarean section to prevent the worsening of perianal disease symptoms. Again, strong, very low-level evidence. There are some studies looking at what happens if women with active perianal disease have vaginal delivery. And essentially, a case series have shown worsening of the symptoms. And active perianal disease also increases the risk of 4th-degree perianal tear. For those with inactive perianal disease, I think the data remains more conflicting. Then there are 4 selected key consensus statements related to pregnancy management. Women with IBD should be in documented remission and medically optimized prior to elective conception. The second is pregnancies for women with IBD should be considered high risk. And I'll explain what we mean by that. Third, women with a current or past history of rectal vaginal fistula, which is stemming from the great statement you heard earlier, should deliver by cesarean section. And last but not least, women with IBD should be assessed early in pregnancy or preconception for nutritional status, weight gain, and micronutrient deficiency. So the body of evidence already suggests that active disease at conception is not good, associated with higher disease activity in pregnancy. And there's a meta-analysis of 14 studies, again showing a higher risk ratio of disease during pregnancy in patients with ulcer colitis who got pregnant when they had active disease. And you could see here, there are also studies looking from the Danish cohort. So IBD should ideally be in remission for at least 3 to 6 months prior to women conceiving in order to optimize pregnancy outcomes. So one of the statements reads that pregnancies in IBD are considered high risk. And we know that uncontrolled disease activity is associated with adverse maternal outcome. So what are these adverse maternal outcomes? We know IBD pregnancies associated with inadequate gestational weight gain. So for example, a weight gain of less than 12 kilograms is associated with adverse pregnancy outcome. And disease activity is also associated with reduced gestational weight gain. There are other adversity, such as preeclampsia. There are already birth cohorts showing higher risk of preeclampsia in mothers with IBD. And on the right, you can see the risk of venous thromboembolic disease is also increased, for example, during pregnancy. So these stems from over 17,000 IBD pregnancies. Data were from systematic review and meta-analysis. So the definition of high-risk pregnancy, what does this mean in different settings globally? I think essentially it means that we should ideally have a specialist IBD pregnancy clinics, fetal maternal medicine clinic, and education for midwives concerning risk to look for. So I just want to summarize for this first part. The first great statement for maternal factors is about suggesting that children with first-degree relatives with IBD as compared to those without have an increased risk. And also that if your parent have Crohn's disease, then you may have a higher risk of developing IBD than a children born to parent with ulcer colitis. And for the summary for the pregnancy management, these are the selected important great statements. And I think one of the most important, what we strong, great really relates to IBD patients going through preconception counseling in order to reduce some of these adverse outcomes. And also, in those with active perineal disease, to think about cesarean section in order to prevent worsening of their perineal disease. And lastly, these are the 4 key consensus statements that we should try to get our patients in remission and medically optimized prior to elective conception, and think about your IBD patients as being high risk and what other counseling is needed. And those with a high risk rectal vaginal fistula to be delivered by C-section. And last but not least, really some of the very obvious things that we think about but sometimes don't practice routinely. Women with IBD should be assessed early in pregnancy or preconception for nutritional status as well as weight gain and micronutrient deficiency. So what you heard really takes a global village. Many of them are sitting in the audience of all the hard work. So thank you.
So I'd like to introduce our next speaker, Cynthia Tsao from the University of Calgary, who will be providing you with a summary on something that is very relevant these days with our numbers of medications, medication use during pregnancy. So Cynthia.
Thank you for the opportunity to present today, and thank you very much to our team, which I can demonstrate here. So I'm covering a big topic on medications in pregnancy, and I want to remind you all that there are no randomized controlled trials of IBD therapies in pregnancy, and unmeasured confounding is innate to all uncontrolled studies. So clearly the level of evidence is not strong, and we have to take considerations when we look at the data. Very importantly, existing disease activity impacts the decision to continue or discontinue therapy. And this decision is not random and does influence the way that we review these studies. Further, there are low event rates for adverse events. And even when we do systematic reviews and meta-analyses, there is imprecision in the data because of these small numbers. Very importantly, can I remind you over and over again that active inflammation is a teratogen, and that is what we are most concerned about. Further, congenital malformations do occur in a proportion of all pregnancies and are not always medication related. Further, when we talk about infections, preterm birth occurs in almost 10% of all deliveries and is a major risk factor for neonatal infections. So it's not always the medications that lead to the adverse events. With this in mind, we have 11 grade statements on medications in pregnancy. We will be covering the conventional therapies, the advanced therapies, with a focus on the outcomes of congenital malformations and infections. And further, for anti-TNFs, we'll look at the impact of continuing or discontinuing therapy on maternal outcomes, as well as preterm birth. We will then review the strength of recommendations as well as the grade quality of evidence. And so this is what we will be covering, but don't worry, we'll take you through it step by step. Very importantly, we also have consensus statements which are based on expert opinion, and it's definitely not black and white, but very much shades of grey, and we'll be covering these topics subsequently. I will give the spoiler alert that this is what the summary of medications in pregnancy is, because we know that there are a lot of statements to be covered. Start discussions about family planning early so informed decisions can be made. Very, very importantly, be much more concerned about active disease and active medications. And remember that adverse outcomes are mostly related to the presence of active disease. So moving on to our grade statements, the first is on 5-ASA therapy and reads, in women with IBD who are pregnant or attempting conception, we recommend continuing maintenance 5-ASA therapy given the evidence does not suggest an increased risk of congenital malformations. The strength of the recommendation is strong and the grade quality of evidence is low. So in summary, there is no increased risk of congenital malformations with exposure to 5-ASA. And from a plausibility point of view, there is no increased risk of infections with this class of drug. What you will see here are the main studies that have looked at 5-ASA and adverse outcomes. There are 2 systematic reviews and meta-analyses and an observational study. And the quality of the evidence was not high because many of these studies mixed 5-ASA with sulfasalazine. I would like to point out the Norgard study, which is a very large observational study that was very cleverly adjusted for a number of factors, including maternal age, BMI, smoking status at time of pregnancy, parity, comorbidities, co-medications, and the sex of the child. And overall, these studies have not shown an increased risk in congenital malformations. I do alert you to the Callan study, which did give some of us concerns initially about the risk of congenital anomalies, especially as CVS anomalies, but the authors clearly stated they could not adjust for important confounders, including corticosteroid and immunosuppressant use, as well as the disease activity of the mother. From a practical consideration point of view, please remember that your UC patients are the ones that are using 5-ASAs. Remember that for pregnant women who have active proctitis or active left-sided disease, that they have urgency, that they have tenesmus, and it's really hard for them when they have a gravid uterus jumping on their rectosigmoid as well. So don't forget the use of rectal 5-ASA therapy. It is safe and very effective for pregnant women with IBD. Also remember that adherence as well as non-adherence to 5-ASAs is very common, and remind your patients to be using this either as an oral and a rectal therapy that is well utilized. Further, we are not concerned anymore about DDP as this is not really used in most of the commercial preparations around the world globally, but there were previous concerns about its use in Asacol and the risk of anogenital anomalies. Moving on to sulfasalazine. In women who are pregnant or attempting conception, we suggest continuing maintenance sulfasalazine, given that evidence does not suggest an increased risk of congenital malformations. Strength of recommendation is conditional and the quality of evidence is very low. Similar to 5-ASA, no increased risk of congenital anomalies with exposure to sulfasalazine, as you can see by this one large systematic review and meta-analysis and observational studies. Again, do not forget the role of rectal 5-ASA therapy as a co-therapy for our UC patients. And remember, if a woman is on sulfasalazine during pregnancy, co-therapy with 2 milligrams of folic acid is recommended. Moving on to corticosteroids. In women who are pregnant, we suggest use of corticosteroids when clinically necessary with appropriate monitoring, as data does not demonstrate an increased risk of congenital malformations or infant infections. Strength of the recommendation is conditional and the quality of evidence is low. This is the systematic review and meta-analysis by Park Wiley. It is a huge systematic review and meta-analysis that did not show an increased risk of congenital malformations. As you can see here, there were over 500 patients that were exposed to corticosteroids and compared with over 50,000 patients in the control group. Why were we even concerned about congenital malformations? There was discussion that if you removed one of the larger studies, the study by Heinonen, the numerator dropped to only 700, and there was a concern about an increased odds ratio of congenital malformations. But I can tell you, with the totality of data with over 50,000 in the control group, we do conclude that there is no increased risk of congenital anomalies. There were concerns about oral cleft and lip from 4 case control studies, but this has not been demonstrated in further observational studies, and we conclude there is no increased risk of congenital anomalies from use of corticosteroids during pregnancy, as you'll see by other large observational studies listed here. In terms of the infection risk, the piano study demonstrated that there were only serious infections at 9 and 12 months with second and third trimester use. Other studies have not demonstrated an increased infection risk. Please be aware, again, that preterm birth is a major risk factor for neonatal infection, and those with active disease are the ones that are more likely to be treated with steroids during a pregnancy. Other practical considerations: don't forget to monitor for the increased risk of gestational diabetes. I'd like you to be aware that topically released corticosteroids are also safe. There have been small studies looking at colonic release as well as ileal release corticosteroids in pregnancy and are deemed to be safe. And again, you can use rectal therapy in your patients, but a large systematic review and meta-analysis by Araldothy did demonstrate that rectal 5-ASA is more effective for our IBD patients than rectal steroid therapy. Moving on to methotrexate. In women with IBD, we recommend discontinuing maintenance methotrexate prior to conception due to a demonstrated increased risk of congenital anomalies among women who continue methotrexate therapy. Strength of the recommendation is strong, but very low level of evidence. There is a syndrome of fetal methotrexate toxicity, which comprises a number of congenital anomalies. This is the data. But look at the sample sizes and the numbers. Even in the largest systematic review of methotrexate in pregnancy, there were only 29 babies with this syndrome of multiple congenital anomalies. Further, the quality of the evidence is really low. As you can see here, there were mixed disease cohorts. It was not specific for methotrexate use in IBD. And further, there was also data that was not specific for methotrexate, but was more pertinent to the whole class of dihydrofolate reductase inhibitors. So from a practical standpoint, please give time to transition and stabilize your pregnant women who are on methotrexate onto other therapies, preferably 3 to 6 months ahead of time. Remember that exposure to methotrexate does not necessarily mean that you should terminate that pregnancy. This should be a very involved discussion because not all women or their babies will have congenital anomalies. And if you can encourage your women to be on folic acid, that is preferable for all pregnancies, as the New England Journal study demonstrated that women who are already on a multivitamin with folic acid had a lower rate of congenital anomalies, even if they were exposed to methotrexate. Moving on to thiopurines, women who are pregnant and attempting conception, we can suggest continuing maintenance thiopurine as this does not increase the risk of congenital malformations or infant infections, strength of recommendation is conditional, quality of evidence is very low. And in summary, there were no statistically significant estimates for congenital malformations or infections, and this is really reassuring. Practical considerations, no increased risk of neonatal anemia in exposed infants. And this graph demonstrates the risk of stopping appropriate therapy in pregnancy. You can see in the green that if you dropped the use of azathioprine preconception or during pregnancy, that the risk of the purple lines, which is the risk of needing steroids, increased. And we've already covered the safety data of that. I know you're going to ask about mono versus combination therapy, as well as the maternal effects of thiopurines. We'll be covering that shortly. On to anti-TNF therapy. In women with IBD who are pregnant or attempting conception, we suggest continuing maintenance anti-TNF therapy throughout pregnancy to reduce maternal disease activity. Strength of recommendations conditional. Quality of evidence is very low. There are 2 systematic reviews that have covered this. And in summary, postpartum disease activity is increased with 3rd trimester discontinuation. There's almost a 2-fold odds ratio increase of having a disease flare. There is so much data demonstrating that we should be continuing effective anti-TNF therapy through pregnancy, as demonstrated by the Mayer Target Trial Emulation Study and a number of observational studies. I would also like to prompt you to think about, how do you define a disease flare? We're talking about clinical disease flares, but we certainly know we treat to target, that we should be very greedy with our endpoints, and we should be monitoring these patients very carefully, as you've already heard, by looking at non-invasive objective markers of inflammation and making sure that these women don't flare. Further, the timing of anti-TNF withdrawal in the studies is not random. These patients were chosen to stop anti-TNF therapy in the studies because they had stable disease. So if we think about the whole cohort, in fact, the estimates of the risk of disease flare are probably underrepresented if you had taken all comers into account. There was heterogeneity regarding immunomodulator use, which can be considered protective as well by improving the pharmacokinetics of infliximab. And lastly, even if you withdrew the anti-TNF in the 3rd trimester, we know that the changes in pharmacokinetics in pregnancy are likely going to be protective, and there was a long half-life of the drug. So ultimately, we do not recommend that women on anti-TNF therapy stop their therapy during pregnancy. We suggest continuing maintenance anti-TNF therapy on schedule throughout pregnancy to reduce preterm birth. This is a conditional recommendation with very low quality of evidence. Remember that preterm birth is the leading cause of neonatal morbidity and mortality globally. And here you can see with a number of studies, particularly the Mayer Target Emulation Trial, that if you stopped anti-TNF during pregnancy, that there was increased risk of preterm birth. So continue your anti-TNF therapy to reduce maternal disease activity and reduce your risk of preterm birth. What about congenital malformations or infections? I'm going to demonstrate that the strength of the recommendation is strong with low quality of evidence. And you can see from this systematic review and meta-analysis that there is no increased risk for congenital malformations if you continue anti-TNF therapy. There are a number of systematic reviews and meta-analyses on this topic showing no increased risk, as well as a number of observational studies. When you look at anti-TNF therapies and infections, note that there are all non-statistically significant estimates. It is safe to continue anti-TNF therapy during pregnancy. It does not increase the risk of infection, but as you will note here, it is preterm birth that's an independent risk factor. And if we backtrack one step, disease activity increases the risk of preterm birth, which increases the risk of neonatal infection. Looking at combination anti-TNF and thiopurine therapy, we recommend continuing this combination as there's no increased risk of congenital malformations or infections. Again, remember that there is bias in who you are treating with combination therapy, as they likely have more active or severe disease. When you look at the data, it does not demonstrate an increased risk of congenital malformations for those who are on combination therapy. And whilst The Mayer study did demonstrate an increased risk of infections. This was only seen in the first year. And remember that either thiopurine monotherapy or anti-TNF monotherapy does not increase the risk of infections. Remember to vaccinate the kids. This will be covered shortly. Moving on to vedolizumab and ustekinumab for the risk of congenital malformations and infections. This is the summary slide for a beautiful study by Mayer et al., which was a propensity score matched study for maternal IBD as well as pregnancy characteristics comparing vedolizumab and ustekinumab exposed infants with those who were on anti-TNF therapy. And very importantly, it showed no increased risk for serious infections, malignancies, or congenital anomalies. There is a multitude of data that has come out recently on vedolizumab and ustekinumab, and we don't expect to read this in detail, but just to say that the Mayer study really does not demonstrate an increased risk of infections or malignancy. Now moving on to the consensus statement. We have covered a number of topics here and we'll go through them together. Consensus statement number one, again based on expert opinion, is that pregnant women with IBD with active disease should start or optimize appropriate IBD therapies as you would do in non-pregnant women, with the exception of thiopurine, methotrexate, and the oral small molecules. And the bottom line here, yet again, is be much more concerned about active disease than active medication. We have made a statement specifically on thiopurine, given the recent FDA announcement at the end of April stating the rare risk of intrahepatic cholestasis of pregnancy. We recommend that women who continue thiopurines during pregnancy, that there should be precautions taken to monitor for this potential adverse effect. We know that the pharmacokinetics of thiopurine metabolism change during pregnancy with an increased ratio of MMP to TGN, but we also know that intrahepatic cholestasis occurs in the general population. Practical considerations of split dosing of thiopurines, allopurinol co-therapy, use of thioguanine, or segueing these patients to biologic monotherapy. Antibiotic use. Women with IBD who are pregnant and have infections, fistulae, or pouchitis may take antibiotics, and all the classes of antibiotics listed here, including quinolones, that includes also fluoroquinolones such as ciprofloxacin, metronidazole, and amoxiclav, have all been deemed safe. Very importantly, treat sepsis, as this is a major risk factor for adverse outcomes in pregnancy. Women with IBD may initiate or continue calcineurin inhibitors during pregnancy with careful monitoring if there are no viable alternative treatment options available. Please note that in the meta-analyses of calcineurin inhibitors, that these were mainly in the transplant population looking at outcomes such as hypertension. They were not in the IBD setting. They were used chronically, and even in that setting, they did not show an increased risk of adverse outcomes. When we use calcineurin inhibitors in IBD, it's used for a short time frame for the treatment of acute severe UC or salvage, and there are just small numbers. But if you are needing to use it, make sure that you monitor carefully and or consider other safer options for use. What about biosimilar use? Women who are pregnant or attempting conception should continue biosimilars during pregnancy. There are small sample sizes in these studies, but we're also aware that in Europe and in Asia that biosimilars have been used as an alternative to originators for the treatment of IBD, and just may not be represented in these studies. Similar to the originator molecule, the biological plausibility is that there's no first trimester transplacental transport, so it is considered safe with no increased risk of anomalies. Similarly, for anti-IL-12/23 therapies, we recommend continuing these. We know that these are IgG1 or IgG4 monoclonal antibodies, but there is no transplacental transfer in the first trimester. And interestingly, from a mechanistic standpoint, perhaps IL-23 inhibition may actually lower the risk of preeclampsia or recurrent spontaneous abortions, but this is still to be determined. Lastly, oral small molecules. There is teratogenicity that has been demonstrated in animal studies, and shared decision making is imperative. Very, very importantly, if electively switching therapies incorporate time to transition to establish remission on other effective and safe IBD therapies, our statements that are going to be listed straight after are based on molecule half-life and product monograph. And if there are no other effective alternate therapies to maintain maternal health, we recommend continuing therapy given the totality of data supports stringent disease control. The statements for ozanimod are that women should discontinue ozanimod at least 3 months prior to conception and discontinue etrasimod 1 to 2 weeks prior to conception, again, based on product half-life. These sphingosine 1 receptor modulators are involved in angiogenesis, cardiogenesis, limb development, and neurogenesis, and fetal death and teratogenicity has been seen at therapeutic doses of ozanimod, but supratherapeutic doses of etrasimod. And there is limited pharmacovigilance data, but only one case of a congenital anomaly. For the JAK inhibitors, we recommend discontinuing all of them 4 weeks prior to conception, but again and again, if you can transition them to other alternative safe therapies prior to the pregnancy, that is considered preferable. There is some animal data for the feticidal and teratogenic effects of JAK inhibitors, and that was demonstrated at supratherapeutic doses of tofacitinib, but therapeutic doses of upadacitinib and filgotinib. Very importantly, the data did demonstrate the most exposed individuals stop the oral small molecules when pregnant. So again, shared decision making is imperative. Incorporate time to switch to more alternative therapies, and only continue therapies if there are no viable alternatives. So in summary, for medications in pregnancy, thank you for listening to all of this. Start discussions about family planning early so informed decisions can be made. Be more concerned regarding active disease and active medication, and adverse outcomes are mostly related to active disease. Thank you.
Yep. As I said earlier, this process was a year in the making, and that was both the talks today so beautifully encapsulated 1 year's worth of work into a very condensed and easy to understand talk. And so we're going to continue in that vein with Mette Julsgaard from Denmark, from Aarhus University, who's going to be talking about safety of lactation and vaccines.
Thank you, Uma, and a huge thank you to Helmsley Trust for making this global consensus feasible. And first, I'd like to thank my colleagues globally who have contributed to data regarding lactation and vaccines, especially Maria Chaparro from Spain, who led the vaccine group. So in respect to drugs and lactation, one of the key outcomes are the calculation of the relative infant dose. And it is defined as the weight-adjusted percentage of the maternal dose. And a relative infant dose of less than 10% is considered relatively safe for most drugs. And just bear in mind, we have very limited data in relation to drugs and lactation. So our first great statement, we recommend that breastfeeding is not associated with an increased risk of disease flare in women with IBD. One meta-analysis was conducted based on 4 studies, including 543 women who gave birth, of whom 414 breastfed. Overall, no effect of breastfeeding on postpartum disease activity. I just want to highlight an American study by Susan Kane showing that 3 out of 4 women discontinued medical treatment prior to commencing breastfeeding. And the group of women who discontinued treatment, they were at increased risk of disease activity in the postpartum period. So this clearly underscores that it's important that women continue treatment for IBD during the postpartum period. Just quickly highlighting that mothers with IBD on 5-ASA and sulfasalazine thiopurines, and corticosteroids may breastfeed. Moving on to the consensus statements regarding monoclonal antibodies and breastfeeding. So women breastfeeding whilst receiving monoclonal antibodies may breastfeed, and that includes biosimilars. Just going back to a bit of basics. So after administration of a monoclonal antibody, subcutaneously or intravenous, theoretically, the dosage in maternal serum will be 100%. It has been shown in numerous studies on IBD monoclonal antibodies that these drugs penetrate poorly into breast milk. There'll be less than 1% in maternal breast milk. 50% of this dosage is actually digested, resulting in less than 0.5% in the infant's GI tract. And only 0.1% is actually absorbed. So theoretically, the dosage in infant serum will be less than 0.005%, so slim to none. And from clinical studies, we also know that infants exposed to both TNF inhibitors, vedolizumab and ustekinumab, when investigating clearance of these drugs, breastfeeding whilst the mom receives monoclonal antibodies does not affect clearance of the drug. So again, this emphasizes the safety of using monoclonal antibodies whilst breastfeeding. Moving on to infections, we now have data on more than 300 infants being exposed to TNF inhibitors whilst the mom breastfeeds. For anti-integrenes and anti-IL-12 and 23s, we have more than 200 cases, and follow-up varies on these infants, but in average 12 months, showing no increased risk of infections. And from the American Piano Registry, we also know that these infants' growth and development are normal. We have no data when it comes to the new IL-23s, nor have we data in respect to lactation for biosimilars. However, these drugs are also IBD monoclonal antibodies. So using these whilst breastfeeding is low risk. So you can use monoclonal antibodies and biosimilars whilst breastfeeding. Moving on to S1Ps. So infants of mothers with IBD currently on a S1P should not breastfeed. For now, we have no human available data in respect to etrasimod or ozanimod. In Europe, EMA has labeled these drugs as do not breastfeed. In the United States, FDA has highlighted the need for a risk-benefit evaluation in respect to breastfeeding. And this is due to that the plasma protein binding is really, really high for both the drug and the active metabolites. So theoretically, the transfer of these drugs to human milk should be really low. However, until we have human data to confirm this, breastfeeding should be avoided while receiving a S1P. Moving on to JAKs. So infants of mothers with IBD currently on a JAK inhibitor should not breastfeed. We now have 2 case reports on women receiving tofacitinib while lactating. In both cases, the relative infant dose was 3.4%, and you may say that this is below the arbitrary cutoff of 10%. However, one needs to bear in mind that these drugs are orally administered, and the bioavailability in the gut is 93%. And we do not know what kind of effects this absorption of the drug may have on the neonates' developing immune system. We have very limited safety data. There's been reports on 3 infants who were exposed to tofacitinib during pregnancy and breastfeeding, showing normal developmental milestones during the first few months of life. 1 Canadian infant had a immunological assessment at 3 months of life, and everything was normal, but that's it. That's the data we got up until now. For UPA and filgotinib, both the EMA and the FDA recommend avoidance of breastfeeding. So we recommend that due to no or very limited human safety data, including unknown effects on the immune system of the suckling infant, breastfeeding should be avoided in case of treatment with a JAK inhibitor. So moving on to vaccines, we recommend that inactive vaccines in children born to mothers with IBD on a anti-TNF agent have comparable efficacy when compared to those without exposure. Numerous studies have investigated this, and it's been highlighted in a systematic review that there are adequate response to inactive vaccines. Therefore, inactive vaccines have similar efficacy in children exposed in utero to TNF-alpha as compared with controls. Further, we suggest that inactive vaccines in children born to mothers with IBD on a TNF inhibitor have comparable safety and risk of adverse events when compared to those without exposure to TNF-alpha inhibitors. Again, 3 studies comprising more than 100 infants who received an inactive vaccine showed no risk of adverse events. And furthermore, of great importance, normal immune function has also been shown. And now a brand new statement I'm pleased to present on behalf of us, the Global Consensus, that we suggest that live rotavirus vaccine may be provided on schedule in children with in utero exposure to TNF-alpha inhibitors. Up until now, we have data for more than 300 infants who have received the live rotavirus vaccine with no serious adverse events. A systematic review, the meta-analysis, showed low risk of minor adverse events, which is really comparable to the background population. And most recently, a very novel study from the Canadian Immunization Research Network investigated immunological assessment of 191 infants exposed to biologics, primarily a TNF-alpha inhibitor. They recommended rotavirus vaccines in the vast majority of infants. And bear in mind, the vast majority of these infants, 93%, were exposed to biologics throughout pregnancy. At the end of follow-up of the study, 150 infants had completed the rotavirus vaccine series. There were no reports of serious adverse events, and no infants required medical attention for symptoms related to rotavirus vaccine. So we conclude rotavirus vaccines can be offered to infants exposed to TNF-alpha inhibitors on schedule. And this has actually already been implemented in Canada based on the Canadian study. Moving on to BCG vaccine. So we recommend that live BCG vaccines be avoided in the first 6 months of life in children with exposure during pregnancy to a TNF-alpha inhibitor due to increased risk of disseminated tuberculosis and associated mortality. So a systematic review looking at infants exposed during pregnancy to a biologic, primarily a TNF-alpha inhibitor, revealed that during the first 6 months of life, those were the infants who were exposed increased risk of an adverse event. One child died of disseminated tuberculosis after being exposed to infliximab throughout pregnancy. BCG vaccination was administered at 3 months of life, and the child died at 4.5 months of life of disseminated tuberculosis. Minor adverse events was low. Other registries from the United Kingdom has uncovered 4 deaths related to BCG vaccine in infants exposed to a TNF-alpha inhibitor. However, we have no details on the age of the infants, the TNF-alpha dose, infants' comorbidity, nor any immunological assessment. So we have no insight into these deaths. When looking at clearance of infliximab after exposure, we know that 1 in 4 infants have low but detectable infliximab levels. Clearance may take up to 1 year, but we do not know if, and if so, what kind of level may cause harm, if any. There are definitely considerations to take into account. Local risk of tuberculosis. If the risk is high, then you really need to weigh the risk versus benefits of administering a live BCG vaccine even prior to 6 months of life. And if so, we recommend a immunological assessment and, if feasible, measurement of the drug. but last but not least, most importantly, shared decision making with the parents. And live vaccines can be given to infants of mothers with IBD who breastfeed while on biologics. We want to raise awareness to this, especially after a recommendation made by EMA last year. So really, I touched bases on this early on. The relative infant dose is extremely low. Infants exposed in pregnancy, we know that clearance is not affected by breastfeeding, and from the PIANA registries and other studies, we know the risk of infection is similar among breastfed and non-breastfed infants. So finally, children exposed to a JAK inhibitor or a S1P during pregnancy may receive Lyme vaccines after 1 month of life. Of course, we have no current safety data or efficacy data. However, the JAK inhibitors and S1Ps have a very short half-life. So clearance will most likely be within a very short time frame. So live vaccines from 1 month of life seems of low risk. So in summary, breastfeeding is not associated with an increased risk of disease activity in IBD. Most drugs used to treat IBD are compatible with breastfeeding. Avoid breastfeeding while on a S1P or a JAK inhibitor. In respect to vaccines, inactive vaccines should be given on schedule. Live rotavirus vaccine can be provided on schedule in infants exposed during pregnancy to a TNF-alpha inhibitor. Live BCG vaccine should be avoided during the first 6 months of life after exposure to a TNF-alpha inhibitor. And infants exposed to a JAK inhibitor or S1P receptor modulator during pregnancy may receive live vaccines at 1 month of life. And most likely, the most important key message of today, if you need any information on drugs and lactations, please download this app, LactRx. You will find all data listed in the drugs and lactation database. Thank you.
Thank you. And our final speaker of the session is Dr. Joanna Torres, who will be speaking to us on pregnancy and fetal outcomes. Thank you very much.
Thank you. So I would like to take this opportunity to thank Uma and Yuli for bringing everyone together across the globe. I think it's really amazing. It's a tremendous initiative, and thank you so much for involving me. So I'm speaking on pregnancy and fetal outcomes, which is actually the reason why we need to discuss so much pregnancy in IBD. And as Uma and Yuli have explained, this represents the work of many people that reviewed the evidence. And so I'm representing the working group members that were involved in reviewing the evidence and coming up with the statements for pregnancy, fetal, and neonatal outcomes. And so special thanks to Susie Kane, who was leading that as well. And so we know that pregnancy is a very dynamic period in a woman's life. Sue explained that there are a lot of metabolic, hormonal, microbiome, and immunological changes that need to occur in a very synchronized way so that a healthy pregnancy occurs and that a healthy baby is delivered. So you can imagine that if there is an underlying inflammatory condition such as IBD, that this interaction becomes a little more complicated. And indeed, it has been shown that having inflammatory bowel disease may increase the risk of maternal, fetal, and obstetric complications. So I'm going to review some of the major outcomes associated with pregnancy in the setting of IBD, for which there is more evidence, specifically preterm delivery, spontaneous abortion, venous thrombotic events, preeclampsia, as well as fetal-related outcomes such as small for gestational age, low birth weight, as well as increased rate of neonatal ICU admissions and hospitalization. So you can imagine that there have been so many studies looking into these pregnancy outcomes and fetal-related outcomes throughout the literature, mostly retrospective studies. There are several large population-based data, especially from the Nordic countries. We recognize that usually disease activity is measured using surrogates such as hospitalization or need for steroids. But nonetheless, we have accumulated, I think, a lot of evidence, and several meta-analyses have tried to synthesize this evidence, and I'm putting them here. And so here is a meta-analysis by O'Toole in 2015. 15,000 women with IBD were compared to actually more than 4 million controlled pregnant women, looking into the risk of preterm delivery. And you can see indeed that women with IBD were more likely to deliver preterm babies with an odds ratio of 1.85. They stratified Crohn's and ulcerative colitis, similar odds ratio, 1.77. Just would like to highlight the very low I-square, indicating very consistent effect or findings across studies. So in regards to delivering babies small for gestational age or low birth weight, also throughout the studies and actually all the meta-analyses have confirmed that women with IBD are more likely to deliver babies that are small for gestational age or low birth weight babies with odds ratio of 1.3, 1.7. And so therefore, based on this evidence, the pregnancy global consensus has suggested that women with IBD, as compared to women without IBD, have an increased risk of adverse pregnancy outcomes, including low birth weight and preterm delivery. So I think my colleagues have really emphasized the importance of keeping disease under control and the importance of disease activity. And this is because indeed most studies, and I would say the majority of studies, have indicated that disease activity plays an important role in these adverse pregnancy outcomes. So I would like to show this study from France, over 30,000 patients with IBD compared to over 8 million controls. And here in this table, I think it's maybe a little small, but I will guide you through it. You can see that they stratified active IBD in the 6 months before pregnancy and active IBD during pregnancy as compared to a reference non-IBD control, adjusting for multiple confounders. And so you can see that IBD, non-active IBD, as compared to controls, is associated with an increased risk for preterm birth, low birth weight, small for gestational age, C-section, and pregnancy-related hospitalization. But if you look into the estimates of risk into the adjusted odds ratio, you can see that it's actually higher always in the presence of active IBD before or during pregnancy. And so this evidence has been synthesized also in meta-analysis. This is the latest meta-analysis looking into disease activity. Almost 7,000 pregnant women with IBD, roughly 1/3 with active as compared to 2/3 with inactive IBD. Different definitions for disease activity. But when you compare for all of these outcomes, preterm birth, low birth weight, small for gestational age, you can appreciate that having active disease during pregnancy was associated with a significantly higher odds ratio for all of these outcomes for women with IBD, for women with ulcerative colitis, and Crohn's disease. So I think it's really very, very important to control disease activity. And so therefore, based on this evidence, we suggest that children born to women with active IBD have an increased rate of small for gestational age and low birth weight compared to children born to women with inactive IBD. So when we discuss the rates of spontaneous abortion, so this is fetal loss below the age of 20 weeks, I think one of the best pieces of evidence comes from the Piano study. We have here the lead author, amazing effort, 1,500 pregnant women recruited, close to 1,000 entering the cohort below gestational age of 20th week. And they look into the rate of spontaneous abortion here in this cohort, 4%. And after looking at different risk factors, including medication, you can see that it was not medication, it was active disease that was associated with an increased risk for spontaneous abortion, as well as a prior history of spontaneous abortion. And so these findings were also confirmed in a Korean population-based study. More than 2,000 pregnant women with IBD matched to 10 controls. Overall, the rate of spontaneous abortion was not significantly higher in women with IBD, but when they stratified according to disease severity, that was defined here as the use of steroids, anti-TNF, or history of surgery, they could see indeed that having severe disease was associated with a significantly higher adjusted odds ratio for spontaneous abortion. And therefore, the consensus has suggested that women with IBD with moderate to severe activity of disease have an increased risk of spontaneous abortion as compared to women without IBD or to women with mild inflammatory bowel disease. And I know that some of these statements have already been shown by Sue, but I think it's always nice to emphasize the need for controlling disease activity, for appropriately monitoring pregnant women during pregnancy. And therefore, we have several consensus statements on this need. So women with IBD should ideally be in objective remission for 3 to 6 months and medically optimized prior to elective conception, because we know if they are getting pregnant with inactive disease, the chances that disease will remain inactive during pregnancy are higher. Women with IBD should be assessed early in pregnancy or preconception for nutritional status, weight gain, and micronutrient deficiency. There is inadequate gestational weight gain documented in women with IBD, and so it's very important to monitor and document that and act on that. And finally, controlling disease activity during pregnancy among women with IBD is critical to reduce adverse outcomes. So preeclampsia is a very severe complication of pregnancy. It typically affects 2 to 5% of pregnant women, and is one of the leading causes of maternal and perinatal morbidity and also mortality. So there is inconsistent evidence in regards to preeclampsia, but the largest cohorts looking into preeclampsia and IBD, which I'm listing here, so data from the Danish National Birth Cohort, showing that even if the overall preeclampsia rate was not elevated in women with IBD, severe preeclampsia was indeed elevated in women with IBD with an odds ratio of 2.24, and the National Inpatient Survey from US showing a higher risk of preeclampsia or eclampsia in women with Crohn's disease. So, of course, that there is the need to try to predict and to prevent this very severe complication. There has been in non-IBD women a randomized controlled study where women at high risk for preterm preeclampsia were randomized to receive aspirin at the dose of 150 milligrams a day from the 11th to the 14th week until the 36th week of gestation. And indeed, this study showed that in these women at high risk for preterm preeclampsia, there was a significant reduction in the rates of preterm eclampsia by receiving aspirin. So importantly, many obstetricians may be concerned of offering aspirin to women with IBD because of the risk of flaring. And so there have been some retrospective cohorts studied, I think mostly from US, from Uma Mahadevan's group and also Marla Dubinsky, looking into women with IBD who took aspirin during pregnancy and not being able to document any increased risk of flaring. And therefore, given the potential for preventing a very severe complication and low risk of flaring by taking low dose aspirin, the consensus has suggested that pregnant women with IBD take low dose aspirin to prevent preterm preeclampsia. So we know that overall IBD is associated with an increased risk for venous thrombotic events. Pregnancy and the postpartum period are also additional risk factors. Disease activity is additional risk factor. And there have been several studies looking into the risk of venous thrombotic events during pregnancy and in the postpartum, showing indeed a higher risk for this complication, both during pregnancy and in the postpartum period. The risk seems to be slightly higher, according to this meta-analysis, in patients with ulcerative colitis, but it's also significantly elevated in women with Crohn's disease. There's a signal, even if it's not significant, for disease flares to increase this risk, which I think makes all sense. So prophylaxis for these complications should be considered. And so the consensus has suggested that pregnant women with IBD have an increased risk of VTE during pregnancy and also during the postpartum period as compared to pregnant women without IBD. So we have reviewed, I think, a lot of pregnancy adverse outcomes that our patients may be at higher risk for, such as small for gestational age, preterm birth, low birth weight, increased risk for preeclampsia. There's also increased risk for preterm pre-labor rupture of membranes, among others. And we know that these are all risk factors for postpartum neonatal complications. And we reviewed the evidence, and I'll show you in a moment, suggesting that children born to women with IBD may have an increased rate of neonatal ICU admission and hospitalizations in the first year of life as compared to children born to women without IBD. So this is meta-analysis looking into the rates of NICU admission, so neonatal intensive care admission, both in observational studies and in registry studies showing a higher risk supporting our statement. And I would like to show this study from Denmark. Over 1 million leaf singletons from almost 8,000 women, almost 8,000 babies born to women with IBD, looking at hospitalization for infectious diseases, as well as prescription for systemic antibiotics, adjusting for confounders. And you can see that indeed there was a higher hazardous ratio, more pronounced in those babies that were born to women with Crohn's, but also higher in born to women with ulcerative colitis. And here we see the breakdown by age. And you can see indeed that those babies, especially born to women with Crohn's disease, may have higher rates of hospitalization, which is explained by the outcomes that I just described, these rates of preterm birth, small for gestational age, etc. So, in summary, I think, throughout the panel, we discussed that our female patients pregnant may have increased risk of pregnancy and fetal-related complications. Very importantly, it's disease activity that drives most of these complications. It's not medication. And therefore, adequate disease control before and during pregnancy, as well as regular and adequate monitoring, is recommended to increase the chances of a successful pregnancy. So thank you very much for your attention.
Thank you. So this one's on? Yes. Great. So now this is open for questions from the microphone, and we also have questions on the app. The first one asks, when will this be published? So we hope to submit this over the summer, and we have agreement from 6 different GI journals to publish it simultaneously upon review and acceptance. So we hope that you'll see this by the end of the year. And the first question, please.
Russ Cohen, Chicago. Thank you. Congratulations. This is well needed. I was at ECHO this spring and watched in horror that the Europeans were still telling patients to stop anti-TNFs at week 26 of their pregnancy. Hopefully they'll change that in their guidelines. Nevertheless, the evidence, that's how you silence me. The evidence that antibiotic exposure in mothers leading to higher rates of IBD in offspring. I want to caution you because the mothers had infections, which is why they got the antibiotics. So I think you really need to separate out whether it's the infections that lead to the higher incidence or the antibiotics, because they generally go together.
Thanks. That's a great point. And I think that's the reason why when we look into the data to dissect out the exact information, I think the first important part is if you look at all the epidemiology studies, they are all in non-IBD mothers, most of them that have an increased risk of IBD in the offspring when they compare the general population. I don't think there are any on whether mothers with IBD were taking antibiotics to have an increased risk. It will be a different study design. And I think exactly because there are many reasons why they may be taking antibiotics. Gastroenteritis, sometimes upper respiratory tract infection, and these are all the confounders. So I think which is why for the actual discussion, I think we need to dissect out this information, and it would be a risk-benefit ratio on these mothers. If the grip B strap infection, then absolutely the mother would actually need that. But if it's empirical over the counter, then so I think that will all go into the discussion. Thanks.
Yeah, let me just say something. The latest IBD pregnancy guidelines from ECHO do not recommend stopping biologics. And Meta was also involved in that. So that was a huge change that we hope will improve pregnancy outcomes.
And I did highlight the ECHO guidelines, but there is this little twist in our statement. We
agree, as stated in the American guidelines, as we state in the PIANO now global consensus, that biologics should be continued throughout pregnancy. But there is this aspect that if a mom who in sustained remission wish to discontinue, then we acknowledge that in case she discontinued in the third trimester, she should restart therapy immediately after delivery. So I think we are quite aligned in that aspect now.
There's one follow-up question from online that Cynthia, I'll ask you. In the past, we had actually tried to time anti-TNFs, meaning you might modify the schedule such that the mother received the infliximab perhaps 8 weeks prior to delivery. Is there any role for timing that now, or should we just continue on schedule?
I would recommend that we continue on schedule for a number of reasons. One, we are never very certain, unless a woman is scheduled for an elective C-section, when the actual date of birth will be, the date of delivery. And so from a logistic standpoint, it is better that a woman continues on scheduled medication so that there is no hiatus to therapy. I think it's also a bit contradictory to tell them to time it when we are so well demonstrating to them that there is no increased risk associated with giving the therapy throughout. So I think it does cause some confusion.
And I agree. In my practice, I'm not altering any timing at this point. We're just continuing on schedule. Okay, we'll take the question from this microphone.
Hi, congratulations. This was great. I'm Kajali from Chicago. I have a question. One of the questions I did have was regarding the timing. Would your statement remain the same for other biologic? I presume so. And the OB world often, in my experience, have raised questions since, we have enough data to say for other abdominal surgeries and other surgeries essentially, but for OB surgery for cesarean, the risk profile is very different. The complication is different. So, a guideline or some consensus statement would really help the providers. The other question that I had was related to the vaccine. For the parts of the world that do give polio vaccine, do you have any recommendations regarding that?
Oral polio vaccine.
Oral polio vaccine, yeah, the live one.
So we did not specifically address oral polio vaccine. I think the recommendation is generally live vaccines after 6 months would be an appropriate time frame. So not before 6 months with exposure to anti-TNFs. And if you needed to give it before, like with BCG, for any reason, you would want to check levels. And if you can, immunophenotype.
Next question from the left hand.
Thank you for those great talks. I'm a GI fellow at Leahy. But if you run into a patient who's on a JAK inhibitor and then became pregnant, what's your process to transition them? Do you stop it recognizing that there might be a gap where they're not on any therapy?
And I'm going to add to that question, Cynthia. There's one here that says, how do you approach a female patient who's failed multiple classes of therapies, finally in remission on upadacitinib? So maybe you can answer both of those.
So I think we really have to emphasize that a woman needs to be on effective therapy. So electively, if there's an opportunity to switch, that should be switched 3 to 6 months ahead of time. My concern would be that if the patient has no other effective therapies, then they should continue the treatment throughout, because your biggest risk here is of flaring during time of conception or early in pregnancy, which can relate to adverse outcomes. We did present the data on cessation, but that was based on the product monograph and that was based on half-lives. But I'll let my other panelists chip in.
And what about the patient who has no other therapies?
Yeah, if a patient has no other therapy, I think we never know when the actual date of conception is going to be. So we would recommend that they continue therapy in order to have the best outcomes for both mum and baby. Of course, it's a very detailed discussion with the mum, though, of course.
Dr. Shapitz.
That was awesome, guys. Seriously, Herculean task. I got a couple of quick hitters. One, do you foresee us writing the low-dose aspirin in this, or do you say us recommending it to the MFM or the OB?
I can take that. I think that the key question here is that we need to tell patients this is okay. What I have started recommending this in my practice, and you get questions back from OBs because they've been taught with Crohn's and UC you shouldn't use NSAIDs, and they put it in the same boat. And so we need to make sure the patient and the OB know that we're comfortable with the aspirin, but I actually have the OB prescribe it.
This is definitely regional because as we learned in our consensus, in some countries, they don't see the OB till the second or third trimester. So I think it depends on where you are, but we recommend starting between 12 to 16 weeks, and it's over the counter. But if I also leave it to the OB.
And Adam, remember the dose in the study was actually 150 milligrams of aspirin, which is available in other places, but here in the US, we obviously don't quite have that. And so we've been using an 81 milligram baby aspirin here.
I just want to add that up until now, we did not prescribe aspirin, low dose of aspirin in Denmark, but giving the data available, we have just changed the Danish obstetric guidelines. And from now on, all pregnant ladies in Denmark will be seen by obstetrician around gestation week 12, and they will prescribe the low dose aspirin. So I would highly recommend that.
And you mentioned active perianal disease and C-section. Did you discuss or talk about IPAA and delivery of method? Did I miss it?
Joanna, do you want to take that one?
Yeah, so we have a consensus statement. Active perianal disease should be recommended for C-section. We also suggested that those women with a pouch should go for a C-section.
Did, okay. And then last one, did you guys talk about breastfeeding as a way to potentially prevent IBD in the neonate?
There is a meta-analysis from Ashwin and Krishna's group stating that breastfeeding seems to decrease the risk of developing IBD. However, more recently, a large Danish population-based registry study published by Manasa Gravel showing there's no link between breastfeeding and the risk of developing IBD in later life. I guess we should add it to the global consensus. We haven't done that for now, but definitely as a discussion point. Yeah.
And I think that's a really important point, and exactly because the epi data is so controversial, and I think we're trying to really understand the mechanisms behind. Because the last thing we want is to discourage them to breastfeed or to encourage, because the ones we found is it's only protective for a certain period of time for the prevention of IBD. Like in the Asian data, it's got to be 12 months or longer, which sometimes is not possible. So I think the jury is still out, but I think it's something we will need to dig deeper into the mechanism.
Yeah, and remember, none of the studies were in IBD moms breastfeeding.
And then one last question. Because
Adam, when he's got the mic.
none of us want to hear from Asher, let's be clear. So what about men? What about the spouses of people who may have IBD, maybe on something like methotrexate or other medications?
That's another guideline.
That's okay. No, I didn't know if that was going to be another section later on.
We tackled all we could for this iteration.
Asher.
All right, so I have 9 more questions that Adam asked me to ask. I've been saying for years, and Uma knows this, this is like a national, now international treasure. And Uma, when are you going to finally publish this damn thing? And this looks like it's going to really be, a breakthrough and change lives. It's unbelievable, this piece of work. I can't think of such a monumental piece of work that has such broad
this is
impact.
Coming from the person who is a senior author on my very first poster as an intern.
All right, we won't talk about that. Anyway, this is my question. I want to almost say, I ban you from saying the words shared decision making, and it's up to the patient. I need to get some guidance. In a patient who needs surgery, but not urgently, let's say Crohn's disease patient, a woman who's, and this is the other question, do you make differences in different trimesters? Needs surgery, but could wait, like low grade, constant, stricturing disease. No doubt she needs surgery today, but she's not obstructed. You see every med, but they're still having 640 bounds a day. How do you deal with the surgery question? They really do need it. How long do you nurse them along?
Perfect. So we did address this. Believe it or not, what you all saw this morning was only about 5 groups of the 10 worth of the data that we did consider. So when you actually read the consensus guideline, you'll see a complete picture of the care from prenatal to postpartum for patients with IBD. We will have a graded statement that states that surgery should be performed when indicated and not based on trimester, meaning if that patient needs to go to surgery, they should go to surgery regardless of the trimester.
Let's say, well, is there one trimester, like let's say first, that you really try nursing along?
No, the data
The
don't
second.
show that.
And no fetal loss in first trimester with
Well, so there are a lot of confounding factors, correct, based on the degree of inflammation, how sick the patient is, but we do not see differential fetal losses by trimester.
Absolutely. And I think a lot of them are based on sort of case series. And in each trimester, there are just equal numbers of different postnatal adverse outcomes.
I'm going to go back to Russ and
A quick comment. Actually, in non-pregnant patients, Joe Pico, our group, showed that low-dose aspirin can be given for cardiac prophylaxis. I warn you, please, with the EMR, when you're doing colonoscopies, identify all the patients who list aspirin as an allergy and take it out of their EMR unless they're truly allergic to aspirin. As clarified, because many of our IBD patients were told don't take aspirin NSAIDs and incorrectly listed as an allergy. Because believe me, your patient comes to the ER with an MI, you want them to get their aspirin and not avoid it because of incorrect listing.
Great. No, it's a good point. I see that a great deal in the endoscopy suite. Susie.
Yes, thank you. Sticking to the aspirin issue here. So it sounds like you tell the OBs to give it. I push back a little bit and say, UMA has shown us that it is not harmful to give it. And I have patients who can't get in to see an OB until week 15 or 16, right? And so timing is important here. So you have to give it if you want to have that protective effect before week 15. So logistically,
Correct.
I feel comfortable prescribing it for those reasons.
No, it's a great point, and it's based on local resources. I agree with you, Susie. If there's going to be a delay in care, I would absolutely prescribe it. In our site, typically the mother is seen around 10 weeks, and so that is the time period. Remember that you want to start this, the time period of importance is kind of that 10, 11 weeks on to 34 weeks. Okay, so our next question from online, again, has to do with our new rotavirus recommendation. So Meta, I'll have you take this one. The question is, are there any concerns about any of the other biologics, whether that be vedolizumab or the IL-23s in regards to the rotavirus vaccine?
Oh, thank you for that question, Millie. So far, we haven't got any data available. That personally, I think there might be an issue, or could be potentially be in respect to vedolizumab. It might not be as efficient, but we do not know as of now. So I would still recommend live rotavirus vaccine in non-TNF alpha treated patients as well. But we really need the data both in respect to efficacy and risk of adverse event. But it looks really promising looking at the data from Canada.
Joanna, would you consider postpartum anticoagulation due to a heightened VTE risk?
Yeah, for those women after C-section, for sure. Yeah.
Joanna, are there other implications in terms of that postpartum VTE risk? Often women are told to initiate contraception kind of at that postpartum visit. Does it influence your contraception choice at all? That risk, whether we should be using estrogen-containing oral contraception?
No, I don't think so. So I would consider heparin, low molecular weight heparin for those women that are admitted to the hospital, like any other patient, flaring, and after C-section for at least 6 weeks. This is also in line with the ECHO guidelines for pregnancy. But I think it's, the usual contraception that they would use.
Sarah.
Yeah, congratulations, everyone. I'm Sarah Street from Stanford, and I'm wondering if you commented at all on their proactive monitoring of levels in symptomatic pregnant patients. It may have been beyond the scope of this work, but how to interpret those in a symptomatic patient.
Cynthia?
I mean, ultimately, I think that it's all about the control of active disease. We are not recommending or suggesting the need for serial drug monitoring during pregnancy. So whatever dose the patient requires in order to get the disease under control, I would take it as the same strategy as I would in a non-pregnant woman.
And just to follow up, the impact of serum level changes during pregnancy physiologically.
Oh,
Yeah, so we do have data on changes in pharmacokinetics of agents during pregnancy. So it is true that for infliximab, we do see the levels rise across the second and third trimester, whereas other agents appear to be fairly stable during pregnancy. But that at this time does not change our dosing. We have seen, levels, it's been examined in the mothers, in the cord blood, in the infants, but it does not appear to directly correlate with the risk of infection or other safety concerns.
Great, thank you. And with that, prior to finally concluding the session, I just wanted to give a big thank you to our chair, who really conceptualized this amazing consensus statement and brought people together from all over the world to improve the lives of our patients with inflammatory bowel disease. So kudos to Dr. Mahadevan, to my left.
Thank you. This is definitely a group effort. These are the people who did all the work.
And with that, we will conclude this session and look forward to having the publication for you all later this year.